if you've got a pain patient who's got high blood pressure and the blood pressure is not well controlled, and you go, oh, well, that must be the pain. Well, it could be the pain, but it could also be untreated sleep disorder breathing.
Mm.
Same thing about nocturia, same thing with morning headaches, same thing with fatigue and sleepiness and tiredness during the day. So all those things can be assessed as factors that are relevant to make you say, well, why are we attributing this only to pain? Why don't we consider that a more advanced sleep test in a sleep laboratory is needed?
Welcome back, everyone, to another episode of Wellness at the Speed of Light podcast. I'm your host, Dr. Stefano Sinicropi, and I could not be more excited today to have Dr. Barry Krakow on our podcast. He is a world's expert on sleep medicine, and I've really been looking forward to this for a long time because sleep is such an integral part of us being healthy and well, both for our physical and mental health. And from my experience personally and my own personal struggles with sleep, and I'm hoping to learn something about what I can do to sleep better as a surgeon and an entrepreneur and somebody whose brain is never going, but more for my patients and for people that are watching this podcast. Sleep is such an integral part of the pillars that we always talk about on the show, and really being the CEO of your own health. So on that note, thanks, Doc, for joining us on today's program, and really looking forward to your advice on what we can do to sleep better, feel better, but really how important it is for people that have serious mental health conditions, serious physical conditions, how important it is for them to get their act in order when it comes to sleep.
Thank you very much.
On that note, I mean, just so the way I really like to start it is, tell me about what interested you so much about this going into the focusing on sleep and how important it is. Was this something that you always knew when you were at medical school at University of Maryland? Were you always like, oh my God, sleep is this is what I want to do, kind of when I grow up? Or is it something that you evolved into over the course of your career?
Well, the way I look at things in general is that divine providence determines most things, if not all things. But for sure, I am in the field of sleep medicine through divine providence. I always had sleep problems as a teenager, serious sleep problems, never really recognized it, never did anything about it. Nothing I could do back then. This is the 1960s. When I went to medical school and finished a residency training in internal medicine, I ended up working in emergency medicine. But in 1988, I was going through a process of trying to figure out what I wanted to do in medicine. Was it going to be emergency medicine, internal medicine, addiction medicine? I had been involved in all three of these things. But I actually wanted to do something else. I wanted to write. I wanted to be a writer. I wanted to write screenplays and novels and things like that. And I said, why don't I try writing an article for a newspaper? Because that's a good start. Just learn some more writing. So I wrote an article about nightmares, treating nightmares, 1988, because I had a family member who had this problem. They called me up and said, you're a doctor. What do you do about nightmares? I said, well, I don't know. So I went to the library and I read about all this stuff about nightmare treatment, of which there's very little. I wrote a really interesting article about it. I took it to my newspaper, local newspaper, Albuquerque Journal. And the editor sat me down and she looked at my article and she read it and she goes, you're a doctor. This is really well written. Like, what's wrong? Like, how did you write such a good article about nightmares? I said, well, because it's just interesting. She goes, well, there's one thing missing in your article. I said, all right, what's that? She says, well, there's no personal angle. You just described all of this stuff. It's really interesting, but you didn't tell a story. I said, okay, fine. Well, I could probably search the world and find some nightmare patients. So, I'll get somebody. She goes, I have an easier solution for you. What's that? Well, did you know that at the same university you're working, the University of New Mexico Department of Psychiatry, they are currently doing research on the treatment of chronic nightmares. Now, do you know how many places in the world in 1988 were doing treatment studies on chronic nightmares? Can you guess?
Two.
Well, there were two, and both of them were in New Mexico. There may have been three others in a couple of other places. So here I am, and I got involved with this research with this team. And from that point forward, I became so fascinated with sleep. That's how I got involved in sleep medicine. And once I got involved and began looking at my own sleep problems, I was like, wow, this is great. I keep learning more and more things about my own sleep. So I think I'm going to stay in this field.
You're absolutely right. I think me too. I'm with you. I think everything's divine providence. It's interesting. Like one of the things, Steve Jobs said is, you can't connect the dots moving forward. You can only connect them moving backwards. It's one of my favorite things. And it's true because sometimes after it's happened, you can see the way that there was the invisible hand making some of these things for us, and we're put where we're supposed to be. And it's amazing because even if I think about my own personal journey, forget about becoming, an orthopedic spine surgeon, but now going down this road of integrative medicine and really trying to learn everything I can outside of kind of what I was taught, breaking these silo mentalities that even that I have. I've talked about on numerous podcasts, many times, like I just sit around sometimes, when we're in self-thought, and I say, in a million years, I would have never thought I was going to be sitting around on some podcast talking about fertility medicine, psychoneuropharmacology, sleep medicine, all kinds of different psychiatric things that wasn't even on my, but it was just a series of events that put me in this position. And it's just, It's just fascinating to know. And we could do that for anything that's happened to us, but I'm glad that you went down this road because this is a topic that is very misunderstood. People get very bad information about sleep. Everyone's saying some other things. Industry is trying to capitalize on the fact that we don't sleep well by selling us things. And I think some of it's great, but some of it is, gimmicky. And then there's all these kinds of supplements and all these other things. I want to start, let's start slow. We got to really slowly introduce people. I mean, it's about why is this such an important concept? You really call, in your book, Life-Saving, Sleep, that we need a radical paradigm shift in the way that we think about treating sleep disorders. There you go, Life-Saving. Yeah, great book. It is fascinating. I learned so much. I mean, I'm a physician. I mean, I know about sleep. I'm in the middle of writing. I mean, I'm actually pretty much done. We're just editing my book, which is general. It's not specific like yours. It just talks about being the CEO of your health. But I've learned a ton on sleep. I'm actually going to go back now and add some of the things I learned from your book and put it in the chapter where, I mean, just a little bit about sleep, but it talks about all the different pillars. But when you talk about how important it is for us to radically shift the way we think about sleep, what do you mean by that? I know especially your passion is a lot in the mental health. And of course, mental health then translates to our physical health. But what's this radical paradigm shift that you talk about?
Well, we have this very large myth in society that's all bound up with number of hours of sleep. And it's true, you need a certain number of hours of sleep, but the obsession with it and the echo chamber effect of it is very problematic because you literally have people going out saying, oh, I'm only getting 7 hours, so maybe I should take a sleeping pill so I get 7.5. There's people actually are thinking this way,
yes,
which is nuts. And sleep hours is secondary to the much larger problem of sleep quality. And the reason sleep quality is missed and misunderstood is it's not an easy thing to self-reflect on unless you learn how to do it. Obviously, if your sleep is crappy, then you go, oh, my sleep is crappy. Is that the way I was born? Is there something wrong with me? Should I do something about it? But most people don't do that. Most people normalize, just like take the problem of nasal congestion.
Mm-hmm.
If you ask a person, how well do you breathe through your nose? They go, breathe through I think I breathe fine. I go, well, that's kind of funny because you're sitting there with your mouth open and you're talking to me. And it sounds like maybe, I don't know, like, are you breathing through your mouth? You breathing through your nose? The point is, people normalize things about their health. Sleep is easily normalized. People wake up and go, that's the way I feel. And then the worst part of it, and this is not a knock against coffee or caffeine, because coffee is probably saved more lives than any drug in the world. I mean, absolutely is the most important stimulant. But once you start using it, then you don't make any effort to analyze your sleep because you just think, okay, well, I'm good to go.
Absolutely. So let's talk about sleep quality, because I think our primary audience, even though there are going to be, physicians and other providers, a lot of the audience is lay. When you say a quality sleep, if you ask the average person on the street, they'll say things like, well, I spent a lot of time in REM sleep, or I had deep sleep, or whatever. What would you categorize if you said this is what I would consider quality sleep? What are the metrics that we're looking at? How do we assess it and say, yes, you've had a good night's quality sleep and now you're going to be functioning at your best?
So the hardest part about this is it's nice to get a sleep study and all that, data, but really you have the ability to look at this in a way and compare yourself to what I would call the normal sleeper. There are actually some normal sleepers out there. They're not widespread. There's probably more bad sleepers than there are normal sleepers. But let me define a normal sleeper, because then a person can say, well, do I meet each of those metrics? So, for example, do I wake up in the morning without an alarm clock, get out of bed, feel great, jump into the shower, start singing, and start having all these creative ideas about what I want to do that day? And then I go have my breakfast, don't drink any coffee, go through the day, have no dip during lunch, have lunch. Maybe if I get a tad sleepy in the afternoon, what do? I walk around my desk for 1 minute and I'm fine. Then the afternoon comes. The evening comes, have dinner. Key point in the evening, am I on the couch watching a screen, or am I active? Am I helping kids with homework? Am I doing volunteer work? Am I doing my own special hobby? Or am I sitting watching something very passively? And then last, when I get into bed, I do this really unusual thing. I get into bed and I go to sleep. And then I sleep through the night. I do not wake up to pee. I do not remember much of any awakenings. If I do, I just roll over and go back to sleep. And when I wake up, I don't have a headache. I don't have a dry mouth. And I feel very much like I want to seize the day because I've got lots of energy, with one caveat. There's something called sleep inertia. It's different in different people, where you might have slept very well, but for some reason, the way you wake up takes a little bit longer.
Mm-hmm.
And you just take, it could be 10 minutes longer. For some people, it could be 30 minutes. It's like, oh, okay, now I'm normal. Not like you had to drink caffeine, but rather just that sleep inertia is holding on to you. But when it's gone, you're fine. So that's a normal person. Now, when you tell that to a group of people and you describe that, they go, who does that? Who are you talking about?
Yep.
And I go, and especially the one that I love the most to talk about is trips to the bathroom, because everybody thinks that so many people go to the bathroom during the night. They're convinced, they're persuaded it's got to be normal. If you go to a urologist will say as much as 1 to 2 times a night is normal. If you go to a sleep doctor, even a sleep doctor can say 1 to 2 nights if they're not up to date on all the research about the relationship between sleep and trips to the bathroom. I have on my website, barrycrakowmd.com, I have a 5-minute video that explains this. But the skinny is, when you have a sleep breathing disorder, it puts pressure on your heart. your heart then reacts and releases a diuretic, its own diuretic into the bloodstream. You make more urine and you get up at night to pee. So most people over the age of 40, particularly, but it can be younger, who tell you they're getting up at night to pee, you go, well, do you know why? And they're going to say, oh, well, I drink too much fluid. I got a prostate problem. I got a bladder problem. I say, okay, fine. That could be. And so what do you find these people doing? Some of them are sleep water restriction. Oh, I stopped drinking at the 6 p.m. Say, well, most people with sleep apnea who treat their sleep apnea can drink a quart of water, a quart, 1 hour before bedtime.
Wow.
And not wake up and pee because their sleep apnea is well treated. So there's a connection that shows you how broad the impact of sleep can be for somebody. And so that's one very important metric. If you know you have that problem of you wake up at night to pee, you have to ask yourself, do you care about that? Well, if you're an insomniac or if you're older, you should care a lot about it because both situations are going to cause problems for you. For the insomniac, you're going to wake up and you're going to have insomnia. For the elderly person, you could trip and fall. In fact, one of the leading causes of hospitalizations and eventually mortality is nocturia, trips to the bathroom at night. And here are all these doctors in the healthcare system completely ignore this research on the relationship between sleep apnea and nocturia. So that's just a starter to whet people's appetite on the idea of sleep quality. But you can go through every phase of sleep and every phase of daytime to ask the question, how does this relate to the quality you had? Specifically, for example, if you found your concentration dipping in the afternoon, you go, well, why is it dipping?
Absolutely. It's interesting because I find that personally, if I get into a situation where I'm sleeping really well, you're right. I won't have the need to get up, during the night. But if it is, for example, if something's going on, or a good example for myself, and I know a lot of people will understand this, as an executive, doing that part of it. If I'm at a meeting and it ends at 10 o'clock at night and I'm wired and I have a million thoughts racing, and then I'm tossing and turning. I mean, I might as well be, awake all night because it's just that normal cycle, and you'll have to get up and go to the bathroom and stuff. But if I had a great day and I was very productive and, did some things with the kids or even worked or had a great day in the operating room or something like that, and then read a book at night after spending some family time, then you're knocked out completely. You wake up the next day, you feel great. And you're doing that. I would say that's less often than not for me personally, even though, I take my, my sleep hygiene routines, which I really want to get into, pretty seriously. But yet it is difficult for us because we're moving, the name of my podcast, my screen's tilted a little bit, so you can't see it today. But, wellness at the speed of light. We always talk about everything at the speed of light, and our society is moving at the speed of light. And it's very different than it was in 1950. We're constantly on our phones. We're constantly stimulated. We're in a hyper stimulated society, which is why, our addictions are getting worse. Because everything's right there at our fingertips. You want something, you get it instantly. You have a thought, you can go and do that instantly. You want to buy something, you go to Amazon.
The speed of light in the wrong direction.
In the wrong direction. So I call it wellness at the speed of light because that's a call to action. But as far as the other speed of light, it's not good. And I've had all kinds of people talk, we talk about like mental health, and we'll get into that in a little bit. But moving at the speed of light is very detrimental for our overall societal mental health. And it's really, really hurt us as far as the direction that all our chronic disease management is going. We're going to get into that because having very poor sleep habits absolutely ties into every chronic disease you can mention. I know that anything, it doesn't matter, right? From every mental health condition to, if you have an autoimmune disorder or you're struggling just with chronic pain. For my patients, I talk about sleep quite a bit because my chronic pain patients, they've they've had surgeries, they have back problems, they have neck problems, whatever, and they're in chronic pain for 20 years. If their sleep hygiene improves, their pain improves, right? And so we can tie that all in. I just want to get to that question, though. I get what you said. I think one of the reasons that a lot of people are giving you negative answers when you say how many people are like this, normal sleepers, is because we're moving at this ridiculous pace. And it's really everybody. It's not just professionals, not just because I'm a physician, I'm moving at this pace. Everybody's, the bus drivers are doing it, busy moms and dads. Everybody's going 100 miles an hour. If you look at parents' schedules for their kids, right, they're color coded. And I'm like, we did not have to think about all this stuff. Even when I was growing up, right, you go outside with your friends, you kick the can, you figure something out, you play some, two-hand touch football. Now it's like these kids are overscheduled. So nobody's sleeping. The parents are not sleeping. The kids are not sleeping. It's pretty crazy. So would you say that that is a major factor in why we have to take this even more seriously? Because obviously mental health, we have a huge mental health crisis and a chronic disease crisis. But would you say that's the primary reason that our sleep quality is maybe worse than it even was, let's say 30 years ago?
I think that's a huge part. There's also the part of anatomy. There's something probably going on in the way the human neck, throat, head structures are changing that are probably affecting the human airway and such that it leads to more crowding and therefore more collapsibility. And so that the rate of sleep disordered breathing is at a shockingly epidemic level that nobody really appreciates, including many people in sleep medicine don't appreciate. They know there's a lot of patients out there, but the volume or the prevalence of this is it's very difficult to imagine that could be this high, but especially because you'd like to think from an evolution point of view, let's say, like why would we be gifted with this particular problem? But I do think there's something I like to tell people, go back and look at pictures that are 100 years old and look at some of the facial structures that you see. And a lot of times, not always, but a lot of times you can find pictures where the predominant facial structure seems to be people with stronger jaws. If you look at pictures nowadays, you see lots more people with narrower or called vertical faces, like what I have, and a smaller jaw or recessed jaw. And these things have been shown by research that if you have that change in your facial structure, it means there's a change in your airway, and your airway is actually smaller. So when I had my sleep problems as a teenager, I never realized why at that time I wanted to nap every day. When I was in my 20s and 30s, I wanted to nap every day. In my 40s, I wanted to nap every day. I never knew what that was about. Only after I became a sleep doctor and I got the great fortune to train with Dr. Christian Guilleminault, who was the greatest living sleep researcher in the world and passed in 2019. He discovered this condition called Upper Airway Resistance Syndrome, which is a subtle, for some people, subtle variant of sleep apnea. That's what I had when I was a teenager. That's what Dr. Guilleminault diagnosed me with in the 1990s. And once I saw that and put it together and got the treatment, I said, oh, this is why I've been sleepy for almost 40 years. And ever since I got that treatment, which is back in the 1990s, I've had energy higher in my life now in my 70s than I ever had as a teenager. It's just a phenomenal change because the level of sleep quality I have is so high.
I mean, that's wonderful. I'm going to take a shot at this, and you tell me what you think, because again, like going down this this path, me personally, in integrative health, I like to try to connect different things, and there's certain things that I talk about constantly. So here's my shot at why the upper airway problem, and I'll get to the jaw thing and the kind of the facial structure in a second. Every chronic disease is on the rise today. Every one of them, right? Well, the only thing we've done well at is starting to decrease smoking, because if people hear enough, they're going to die if they smoke. At least a small percentage of the population is not going to do it. But I could tell you, I have people coming in for spine consults who are wearing the nasal cannulas, and I just say, okay, we have to have a much bigger discussion. We're not going to do spine surgery on you and kill you, but let's talk about where we can send you. So everything is on the rise. So one, exposure to environmental toxins. I think environmental toxins are devastating. I actually did an episode with this guy that was in the White House, a military guy, and we just talk about like just in that population, how they're exposed to all these crazy things, and they have crazy airway stuff. They have reactive airway disease and everything. They're exposed to burn pits and all kinds of stuff when they're active duty, and then they come back and they get sick. But the toxins that we're surrounded on, including like microplastics and all of these things, I think can make it right, because they inflame all our tissues, and we are mostly in a state of chronic inflammation, which we talk about all the time. The next one is the advent and the rapid development of the processed food industry. And all of the toxins you get in there. I mean, half of the things in there should probably be banned. That's for another, show. But those things can contribute, right? Because if it's helping to create liver disease and kidney disease, obviously, why can't it inflame, the tissues in the airway? So that's it. And then the other one that it all comes together, obesity. Right. I mean, the rates of obesity now are often, even in my 20-year career, the amount of patients that are obese has gotten to a point where when I see people that are not obese in my clinic, I'm somewhat shocked, just because they're not obese, and it's just strange, in our community. So, and obviously those patients, the first thing I ask anybody that has, an over 35 BMI or 40, these people, I always ask them about about sleep apnea. Why? Because it can affect their anesthesia and postoperative complications and also recovery and rest. And now I'm gonna just throw something out there. I just want to get your thing, because I just thoughts that I write down. You talk about like smaller jawline and thinner faces and stuff like that. Could that be all of the toxins that we are exposed to? And this happened, during this century, where we just toxins, there's just toxins everywhere. Could that cause enough endocrine disruption that our bony architecture just doesn't develop the same? So it's not like a long-standing evolutionary thing. It's just, if you're exposed to these things, your endocrine system is screwed up, and now you're producing different bone structures. Because we know, obviously, if we have our testosterone levels are much lower these days. We have all kinds of endocrine disruption. We have thyroid disorders. We can go on and on. Maybe that's why we're suffering from the conditions we're suffering. What do you think about those things I just threw out there?
I think that's a bit parsimonious, because we are talking about growth. Like, how do you grow? Now, we do know another factor occurs in children, in that there's always been evidence that children that breastfeed and breastfeed longer do have better dental arches. But then still, even then, you don't know whether what you're talking about can affect them later on. But a lot of the growth we're talking about is early. It is occurring in those first couple of years. And so the breastfeeding is very important, but nutrition, absolutely. And all the other toxic material you're talking about, I would be surprised if it's not having an influence. And then, of course, genetically, though, if this keeps changing, or epigenetically, these things are not allowing growth to occur at a level. And so also keep in mind, you don't have to be obese to have sleep apnea. Half the people with sleep apnea probably are not obese. So it's something about the airway. The airway is being inflamed, it's being irritated, the growth isn't there the way it should be. I don't know that anybody can put a single thing on it to say this is it, but I would be very surprised if it isn't, with the parsimonious answer isn't multifactorial.
I think that's great. And the more we think like this as physicians, just trying to tie the dots in, and not just, you say, we need to figure out why is all this stuff happening? Because right now, I think you would agree with this, the average American, and we could say that's the same for Canadians, and a North American thing, or a Western medicine, the average person is getting less healthy, not more healthy, with way more issues than we had before. It's funny with the electronic medical record, some of the listing of people's diagnoses, it's so I'm reviewing these things before my clinic. It's like, the last thing you need to do is see the spine surgeon. You need you got to get in. We got to get you in the integrative health clinic, or you need to go see, a functional medicine specialist. You have you have 18 diagnoses and on 50 medicines, of which have all these interactions that I don't even know what's going on. So the average person is not getting better. But let's dive into a little bit of the nuanced stuff with sleep. It's really fascinating. So with this more subtle form of sleep apnea, I have to be honest with you, I have never seen that diagnosis in anybody's chart that I have seen. So number one, how much does that affect things as in compared to kind of frank sleep apnea? And why and I don't want to say nobody, because I'm sure sleep medicine doctors know about this, some anyway, but why does the general medical community not really aware of this more subtle condition? I really want to get into it because it really was fascinating to me when I read your book.
Yeah, this is a very big deal. This represents a huge crisis in the field of sleep medicine because it has failed largely to appreciate the research of Dr. Guilleminault. He made this discovery of upper airway resistance in children in 1982. He made the discovery of it in adults in 1991. So, here we are more than 25, 30, 35 years later, and there's still the majority of sleep doctors do not pay attention to upper airway resistance.
Yes.
But for the audience, I can make it very simple by showing a graphic. It's also in my book. But if this is your airway, well, then if it's closed, that's an apnea. And if you gave somebody some CPAP and you opened up that apnea, that's still not a full open airway. And we call that a hypopnea. So most people have heard about sleep tests, who have heard about sleep tests, say, what is your AHI? Well, that's your apneas and that's your hypopneas. And you go, okay, well, those are breathing events. Dr. Guilleminault showed, again, long time ago, that even when you open it up this much, because that's more than this and it's more than this, that's not the same as this. And so the distance between that hypopnea and normal breathing is upper airway resistance. And that little bit shows up on our very primitive, very, very primitive testing equipment that we use to analyze sleep. And so what happened was, when people first began to recognize this and look at it, there were those doctors that were more research oriented, like myself. So I did clinic and research. Most of those doctors would look and say, oh, that's really interesting. Like, what is that? And Dr. Guilleminault, more than anybody else, along with many other researchers, eventually showed with only that small breathing event, no apneas, no hypopneas, just those little upper airway resistance events, causes high blood pressure, causes insomnia, causes fibromyalgia, causes headaches. I think probably causes POTS, postural orthostatic tachycardia syndrome. I've seen cases reversed like that just by treating upper airway resistance. So, and nocturia, trips to the bathroom. So that little thing ain't so little. And what happens is those patients who go to a sleep center where the doctors are only looking at the apnea and the hypopnea, they will send people away saying, well, you don't have anything. You've got mild sleep apnea. It's not worth it. Just don't sleep on your back. Tape your mouth. Sleep with some pillows. And so what they haven't done is gone in and evaluated the upper airway resistance component. So not only that's number one, but number two, let's say somebody does have sleep apnea, and then they treat them with a PAP machine. When they treat them with CPAP, CPAP often can't treat upper airway resistance because it's too hard. It requires too high of a pressure. The patient hates it and says, stop, stop. So the sleep doctors learned to say, okay, well, we can only do this high of a pressure, so we're just going to give them that. We don't care. This is one of the reasons so many people fail CPAP. People think CPAP is this awful device. And in a way it is, because you can't use it to treat the upper airway resistance. You have to switch somebody to something called bilevel, which is a much more sophisticated device that simply allows the pressure to be higher when you breathe in and lower when you breathe out. So bilevel treats this upper airway resistance. But going back to square one, the sleep centers around the world do not treat upper airway resistance aggressively. They don't diagnose it and they don't treat it in the lab, even though it's mandated by the American Academy of Sleep Medicine to aggressively treat the upper airway resistance component. But what happened was, because the doctors are in this echo chamber thinking that CPAP is the be all end all, they go, well, I tried treating them with CPAP, but they can't tolerate it. So I stopped. Happens all the time. I see coaching clients all the time who come to me and say, I want to get on bilevel, Dr. Krakow. Can you tell me how to convince my sleep doctor how to get me on bilevel? I'm thinking, you you need me to help. I mean, this is crazy. You can't just tell them that you're not doing well on CPAP. You know what the answer is? The sleep doctors give patients. Everybody can learn to use CPAP. Everybody can adapt to CPAP. Everybody can do well in CPAP. All you have to do is try harder. You have to be a good boy. You have to be a good girl and just keep using the machine. I'm telling you the God's honest truth. These are the expressions coming out of the mouths of doctors who are saying to their patients, just keep using CPAP. It's a horrible crisis in the field of sleep medicine because these advanced devices are so much better.
Wow.
We published a paper in a Lancet journal 5 years ago showing there's a very advanced device called ASV, which is the most advanced form of bilevel out there. And we took some really difficult to treat patients, chronic insomniacs, years of insomnia, many with multiple psychiatric conditions, failed all kinds of insomnia treatments in the past. We put one group on CPAP and one group on ASV. No other treatments, no medicines, no sleep hygiene, nothing. Just put them on breathing treatment. Nearly 70% of the people on ASV reported their insomnia was cured. I'm talking about numbers on their scales so low that people in research using medications or cognitive behavioral therapy of insomnia would say, wow, that's as good as we can do. Only 1/4 of the patients on CPAP got anywhere close to that level of success. So there is a way to get this treated, but first you've got to get the sleep center doctors interested in actually treating upper airway resistance. And this is why I'll just bring this point up separately, that I've seen on your podcast that you do lots of stuff that's recognizing how we're going to have to transform things. And I can tell you right now, many sleep centers are not going to go for this. They've already proven to be highly resistant and living in the echo chamber. And if you think about it, what's likely going to happen sooner than later, a wearable could come along and just make this diagnosis. And that means the individual could go somewhere else and say, I just want to buy a bilevel machine.
Yes.
What do I need a sleep doctor for? And that free market approach to medicine is going to happen, and nothing's going to stop it unless, unfortunately, we get some crazy people who think they're going to bring back socialized medicine that's going to control everything. But I think even if people try to do that, there's still going to be a free market entrepreneurial push, and there's going to be a way where people can just go buy these devices and treat themselves. And that's unfortunate because the sleep doctors have so much knowledge, and if they applied themselves, they could be a part of this boom because so many people have this condition, especially amongst mental health patients.
It's fascinating because this is a discussion I've never heard. I know sleep doctors because obviously so many of our patients have sleep apnea and it is an issue, and it's definitely an issue post-operatively with anesthesia and things like that. And
make sure we talk about the fact that virtually anybody who's a pain patient,
yes,
is going to have sleep apnea, and for two reasons. Do you know why?
I don't know. I just think I don't know. Other than well, my patients are obese. They're waking up at night. There's probably some reflex mechanism that then creates them to be more, more apneic, something along those lines.
Yeah, very close. So one, if you're in pain, you are no doubt fragmenting your sleep. It's almost like
Yes.
having it's like having PTSD.
Right.
You're just hyper aroused all
Yep.
the time. Well, there's been a theory in the scientific literature for 30 years now that says that if you fragment somebody's sleep, you destabilize the airway. The airway becomes more collapsible just by having fragmented sleep. That's how we got so excited and so interested in this research, because in the 1990s, we first noticed that virtually everybody with PTSD had sleep apnea.
Mm.
And people are going, well, that's ridiculous. PTSD is a mental condition. Why would they have sleep apnea? That's just a coincidence. That's an epiphenomena.
Mm.
But now many other researchers are reporting the exact same thing. All these PTSD patients have sleep apnea. Well, how'd that happen? Well, part of it probably was their airway. Part of it could have been exposure in the military.
Mm-hmm.
But another part of it could have been PTSD hyperarousal. So that's the first thing about
Mm.
pain. But the second thing is many pain patients are on opiates, and opiates cause obstructive and central sleep apnea
Yes.
in virtually everybody
Correct.
who's on them chronically. So I'd like to think that pain clinics, and we've approached many of them and asked them to get on board, say, you need a sleep center with your pain clinic because virtually all your patients are going to have that problem.
I mean, listen, this is fascinating, and I can tell you that the pain centers I work with, they don't have that. They just don't. And so because I use some really good sleep doctors in town. I'm actually going to bring this up to them. I'd like to get their like how knowledgeable they are and why they're not offering people the bi-level devices. I just want to go back to a couple of things. We're so aligned in the way we're thinking. You're absolutely correct. We are on the precipice of the biggest paradigm shift in medicine ever, where with personalized medicine, people wanting better, people understanding that our current system is absolutely failing them, not because we don't have good people in our system. It is because they are in, as you say, these echo chambers, which is how we got to the point that we spend more per capita for our US citizens, anybody in the world, but yet you look at every chronic disease and it's getting worse. Right. And now, listen, think about this. We're spending more money we have a $4.4 trillion system, and you are telling me that we have a crisis of airway resistance, okay, upper airway resistance syndrome, and yet people have that. They're not getting treated. So what are we spending? What are we doing? All we do is we react to when people get really sick, when they get these chronic diseases. It's a huge vicious cycle. And right away, yes, we, like for somebody that has an integrative cap on, and I send people all the time for sleep studies because they're like, I think you have, you have sleep apnea. This is something that's interesting because it's bringing up a whole host of things. Because obviously I treat pain patients all the time. But then in our integrative clinics, we see all kinds of stuff. And I think that this should be part of it. And you've literally just on this podcast are going to change the way that I send people out for testing and completely the thing. I mean, and that's why it's amazing to talk to people like you, where you are, somebody who's studied this your whole life. You've trained with literally the best, right, in the world. But yet your message, even to your own colleagues, God, I sound like this is what I talk about all the time. You're an expert at this. You go to your own colleagues, as I do with some of the ideas I have, and they're just kind of, we don't need, just do the same old stuff because that's what they learned and that's what they're going to do. And the even difference is you guys have guidelines that suggest that you should be going down that path, and yet people still are not doing it, which is right. Insane. So this is something I really need to investigate for our integrative health. Let's go to testing. I really want to dive into this. You talk about the traditional tests that we do for sleep apnea are not probably the right tests. What tests are we talking about so our audience knows something they can, what should they be asking for if they're interested in knowing that they have this resistance syndrome?
The beauty here is that it is the right test. The problem is the data isn't just being looked at as it could. Even some of these, you probably have heard the trend now that the insurance companies and COVID and everything has driven this situation where, oh, we don't need the sleep lab anymore. Just do a home test.
Hmm.
Well, some of the home tests actually are very higher quality, and you can actually see some of the airway resistance on those tests. But if you can't see it on that, that's an automatic indication of go to the sleep lab
Uh,
and get a finer test, because there you actually look at the airflow curve. And like the pictures that I have in my book, the Life Saving Sleep book, actually show the schematic pictures of how the airway looks flattened as opposed to just like no air. It's just this little blip on top of the airflow curve showing that it's been flattened. But that flattening means the person's lost 10, 20, maybe even 25% of their air volume. And I like to say to people, just put your hands around your throat and choke yourself 25% and tell me if you think that's a problem or not. How about just 10%? Maybe just choke yourself 10%. And so, of course, it's a problem. And everybody gets that who understands it from, the public's perception. But the fact that sleep doctors don't get it is one of those things about, again, we've said before, echo chamber, group think,
mhm.
herd mentality. And this gets into a very deep psychological problem where people are either ashamed, embarrassed, or fearful that if they are an outlier, they do something that's different, somebody's going to come along and slap them on the hand. Worse, somebody's going to come along and take some kind of legal action. Somebody's going to audit them. When we were doing this research back in the mid 2000s, right around 2005 in particular, we could not understand why our CPAP patients were not getting better. When we opened up our center just a few years earlier in Albuquerque, New Mexico, we knew that we were going to be treating lots of mental health patients because that was our reputation. We've been doing this for years at the university. Then we went into private practice, opened up a private sleep research center, and then a sleep center. And so these people were using CPAP. I said, they're just not getting better. They're not getting better. What's going on? And one day, my colleague, Dominic Melendres, and I, a really great sleep tech, we were looking at the channel and we said, we're missing something here. What are we missing? And we were trying to see how the airflow, you breathe in, that looked kind of good. And then you breathe out and we go, the breathing out just doesn't look right. What does that look right to you? And we kept looking at it over and over again and say, we're missing something here. Like, why does that airflow channel on expiration look so ratty? And the thing that was so funny about it, to show how what's the word, ignorant and blind you are before you actually see something. What were all these people telling us for years about CPAP? Doctor, I can't breathe the CPAP. Doctor, I get claustrophobia with CPAP. I feel like I'm drowning in CPAP. So do you think I could listen to that maybe? You think I could hear people telling me that and say, gee, I wonder if there's a problem? No, it took me over 10 years. So
Wow.
now it's 2005, and we're saying, okay, wait, they keep telling us they can't breathe. So what are we seeing here? And we go, I don't know, but expiration doesn't look right. All right, why don't we try bi-level? I mean, who knows? It's a shot in the dark, let's just try it. And so we did it. And all of a sudden, the airflow curve on expiration looks normal. And then I go back in the scientific literature to 1994. This is 11 years earlier. And I go, what is this article? Oh, it says bi-level can treat somebody's sleep apnea with higher pressure when you breathe in, lower pressure when you breathe out, and that's all you need. And you're done. I go, wait, how come I didn't know that? How come nobody told me that? Anyway, found the article, started people on bi-level from 2005 onward. Now, here's what's important for other doctors to hear. From 2005 onward, we no longer prescribe CPAP. You go, well, wait, how did you, sleep doctors go, how did you do that? I said, very simply, we did two things. One, we went to every medical director, including Medicare, in 2005 and 2006 and spoke to them. We had a conversation. We said, hey guys, You know how bad CPAP failure is? They go, oh, yeah, it's horrible. Well, we think we found something that's going to make a big difference. I say, really? What are you talking about? Bilevel. It was, they tell me more. So we told Medicare, Blue Cross Blue Shield in our local area was called Presbyterian, United, Aetna, Cigna. We spoke to as many medical directors as we could. Every single one of them listened to what we had to say. And they go, well, if that's what you want, just show us like some documentation. So how did we document it? We documented it by bringing the patient into the lab, putting them on the CPAP, showing that problem with expiration that I spoke about, the ratty signal,
Mm-hmm.
switching them to bilevel in the laboratory,
Mm-hmm.
showing how it got better. And then when they finished, you know what that meant? We could prescribe them bilevel. They never even had to try CPAP. So we've been doing that. We did that for 20 years before 15 years before we sold the sleep center in 2020 and moved to Savannah. And in those 15 years, I got a rejection on a bilevel device once or twice out of thousands of patients.
Wow.
So we put everybody on bilevel, auto bilevel, ASV, which is again an auto bilevel type device. And the insurance companies saw the documentation and they said, and of course, these people were mental health patients in general. And so most of them had anxiety, which made them at risk to have this problem with CPAP. There are people who can do extremely well with CPAP. There really are. But that tends to be only 1 out of 3 patients as far as I've seen in my career.
I mean, that is fascinating. A couple of things that you brought up, and I still want to stick on this topic because it's fascinating, and this is it's going to be a new thing for 99.9% of people that watch this or watch the little shorts that we make from it as we talk about this. But I love the fact that you brought two things. One, the why did nobody tell me? I am having these epiphanies constantly. I'm learning about new things by talking about, with experts like yourself or just doing research because I read more than I ever have. I mean, I'll read about anything in medicine because I just want to, have the best tools to help my patients. And then sometimes it's fascinating to say, if this data was already out here and it's this strong, why is no one promoting this stuff? Why is no one helping? Is it because there's not like a good middleman that's making money from it and that's why it's not being brought out? I mean, there's so many different issues that be brought out. If no one's making money from these things, what we found in the light, all this light therapy that we're doing, that there's no one's promoting it. I've never had anyone come to my office and try to promote any of the things that we're currently offering to our patients, but yet it's so highly effective. It's crazy. And I think sometimes it boils down to one, the silo mentality, and there's no middleman. Then the other thing is the fact that there is this fear with going outside of the mainstream, and people are, we feel some shame and embarrassment, or, oh, what are people going to say? We're people too. So physicians are like that. And maybe we're even more sensitive than most people because when we go slightly outside of the path well worn, people do, tend to, things. But the crazy thing is a lot of the things like in integrative health, okay, and this would be under that, guys, because this is really an important topic. Like what you're doing or a lot of the things that we're doing, they're non-invasive, they're non-medication, they're not hurt, the risks to these things are infinitesimally small compared to what we do normally in medicine, but yet people are afraid to step out of the box. And I've said publicly many times that before I went down this path as a spine surgeon, I was like, what are people going to say? What are my colleagues going to say about me? I'm the spine doc, and now I'm talking about all these other topics and, and opening clinics and doing things. And the funny thing is, most of that was in my own mind, because the truth is I'm not saying that people are not skeptical, and I'm sure they'll be skeptical even about what we talk about now, no matter how much data you have. They're open to it. No one's saying, oh my God, look what this guy's doing. No, they're saying, well, that's interesting. Maybe I'm not going to, send my patients for what you're, trying to do. But no one's saying, oh my. So I encourage other people to follow the lead like yourself and say, hey, if I have these other ideas, let's explore them. Let's talk about them. Let's try to bring them out into the mainstream. Let's meet with Medicare and say, hey guys, do you understand how strong this data is? And let's go in that direction. So that's just fascinating because, again, thinking outside the box is so important. And if we're not thinking outside the box, industry is going to come in and think outside the box, or private stuff. But the bottom line is all this stuff's going to get privatized, like you said before, and people are just going to go get their home tests and skip the sleep medicine docs. And then they're not going to have anyone to treat because people are going to just be treating themselves with some AI-based algorithm, and go from there. I just want to go back to the test.
So you bring up, I want to bring up a story in my past about this that speaks to a lot of this, but virtually all doctors, I think, go through a period of soul searching. And it may be several different plateaus they go through in their lives, but there is usually a soul searching period where there's got to be a decision that made. How important is it that I'm there for the patient because I really want them to get better, versus I'm willing to settle back into my routine because this is either comfortable, it seems to work, it's the consensus, I don't have to worry about somebody, whatever. So I bring this up because in 1998, I discovered in myself that my insomnia that I had, it wasn't particularly severe insomnia except for one period in the middle 1990s. I discovered that my insomnia was largely driven by sleep apnea. And when I made that discovery in myself, it transferred over into what I began seeing in my patients, so that this same Dr. Guilleminault that I mentioned to you doing this work in the 1980s, in the 1970s, when he was a neurology resident in Italy, he published a case report showing a link between sleep apnea and insomnia. Nobody had ever done that before. I picked up on that research, and from the 1990s through the 2000s, we were publishing like crazy on the relationship between insomnia and sleep apnea. And I was in a position where I had the sense that we had come upon a discovery that, one, no one in the field of sleep apnea was going to believe. Two, most people who have insomnia won't believe. And three, I don't know what to do with this information, because I kept researching it. But when I would go to conferences, I would actually be in audiences of a couple hundred people. And I was good friends with many of the top insomnia researchers. They'd be standing at a podium giving a talk about something. And in the middle of the talk, somebody would make a joke about my research. They'd say something like, oh, unless, of course, they saw Dr. Krakow and they had sleep apnea. Everybody in the audience would break out laughing. I'd look at my friend Dominic, and we'd look at each other with a very knowing smile, saying, one day, one day, one day, however long it takes. And here we are. This is now 20 years later. Only now do you actually see a few groups just over the last 5 years beginning to push the idea that most chronic insomniacs actually have sleep apnea. Well, do you realize what a game changer that is? In other words, we actually have published data, and others have published data showing that the largest majority of people who are taking sleeping pills and failing, because most people fail sleeping pills, most of those people have sleep apnea. That's why the pill can't work. The pill could probably work in somebody who didn't have sleep apnea, but there aren't that many people with insomnia who don't have it. They do have it. And this is a huge factor. In that period, I'm going to say, I felt extremely isolated. I was actually somewhat fearful because I said, this is just too weird of a discovery. How can these two things be linked together? And that really helped me understand the silo effect, because I realized when I would go talk to one group, they go, what the heck are you talking about?
Yes.
And then I talked to people with the sleep apnea group. This is interesting. The pulmonologists, they go, Barry, it's funny you say that, because I've actually seen a case where somebody came in to see me because they had COPD and asthma, but they also had insomnia. And I said, we need to get a sleep test on you to see what's going on. They had sleep apnea. They treated their sleep apnea, and they came back and their insomnia was gone. So get that. The pulmonologist, he saw it. She saw it. They knew this made sense. But all the neuroscientists, the PhD psychologists, what the hell are you talking about? What do you mean sleep apnea and insomnia? And even to this day, the largest majority of people in the field treating insomnia, neuroscientists, psychologists, psychotherapists, and so on, nope, no idea what you're talking about. This is not relevant to my practice. They don't get it.
That's an amazing story. I mean, it kind of reminds me one of the things we're big on and that we brought into like our integrative health stuff is utilizing transcranial photobiomodulation and treating the outer cortex of the brain with light therapy. And I had some of the gurus in the world. Actually had Michael Hamlin. I mean, he's still alive. He's in his mid 80s. And he's retired now, but he's the guru, and he's, talked about his frustrations because there's good. But I had Dr. Paolo Cassano from Harvard. So he runs the photobiomodulation lab at Harvard. He's an MD, PhD psychiatrist. And he was talking about the incredible changes you can see on the brain with light therapy, penetrating the skull, and what you can do in the psychiatric conditions, what you can do in Alzheimer's. He was talking about the research in primates where there is a model of Parkinson's disease. And he said, you can just see them. They have the tremor, and then you treat them with a bunch of weeks of light therapy to their brain, and it improves. And he gets that same thing. I mean, it is so early, even though it's not. They've been doing this research now for a while. They've been talking about it. They see amazing, and we do it in our clinics. We've seen incredible results for some things, especially TBI and migraine and all these other things. But it's amazing. He says the same thing. It's like they want to get the message out, and these are as low risk as possible. They see it. It's right there. But yet he goes out, he talks to neurologists, he talks to psychiatrists, he talks to all these other people, and they're kind of like, I don't understand. What would that do for I don't understand. He's like, well, why don't you look deeply at the studies? How does this work? What's this technology? And we're so siloed. So yeah, I was just thinking about that because it's almost like an identical, discussion. But that's fascinating. And you know what happens when you keep being persistent like yourself? Eventually, you're like, it's no longer funny, right, guys? Because we're going to make that radical change and make a huge difference. And on that note, I love what you told me before about the pain management patients. I mean, we have to be evaluating all of them for sleep disorders. And I think I need to do personally a better job. I think I need to expand that. Do you think that, because everybody that I see has pain, right? That's why they're seeing me when they see me as a spine. I mean, do you think, would you say that they should all start at least with a home test to see what they've got going on? Would that be the initial first step? And if so, which home test would you advise? What again, I'm not saying, that you're careful to promote anything on the show, but if just what you would advise specifically, not as medical advice, but just as a general guideline.
Well, I actually promote everything because the goal here is, like, even if you start with a wearable, somebody's advertising their wearable, you can get this information that says, it looks like I'm not sleeping that deeply. So, that was a first step. That's a good thing that you got the wearable, because you're looking and you go, oh, well, why does it show I'm not getting a lot of REM, or so, or so it says. But the point is, you get that. Now you're starting to actually self-analyze your own sleep.
Mm-hmm.
The next test could be something to do with oxygen. The next test could be a home sleep study. Home sleep studies in your setting are very efficient, and they will pick up the lowest hanging fruit of those with very severe sleep apnea. The problem is, and this is a huge problem in sleep medicine, the metrics that we use to measure the severity of a sleep breathing disorder are very qualitative, and they're being used quantitatively. In other words, somebody says, oh, you have a high AHI, so you have severe sleep apnea. You have a low AHI, so you have mild sleep apnea. That's wrong. That's absolutely wrong, because amongst mental health patients, they can have mild sleep apnea, moderate upper airway resistance, but the way it's affecting their sleep and the way the sleep is affecting their mental health has so much impact. They would never say this is a mild condition. They'd say, let's treat the condition and find out how much better you feel. Then we'll know what the impact would have been, was, and turned out to be. So there's where you have the problem where you could do these tests and go, okay, well, it looks like the numbers say the following. And so you have to clinically now go back to tell me more about what are your symptoms.
Mm.
Like,
So for either the lay people watching this or providers that say, okay, I'm a believer, this is very, interesting stuff. And I think that we need to explore it further. When we're sending them to, for like, let's say we're going to send you to sleep medicine to get the proper testing, should we be just saying specifically look for upper airway resistance syndrome and consider the bi-level devices? Should be like me as a different specialist, especially when I see them in like an integrative health setting? I could just, is that how, because normally we just send them and say do a consult and they'll
right,
figure it out. But should we be asking for that specifically if they're not really looking for it?
right. So it's a great question. The short answer is yes, you should do that. But if you do tell them that and they say it the way you just said it, they will probably have the door slammed in their face and they'll be told, go to another sleep center.
Hmm.
So that means that if you want to use that information, you're better off using it by looking at the sleep center and asking them the question, by the way, when you test people, do you look at upper area resistance? And number two, when you treat people, do you ever use bilevel?
Hmm.
Now, that is much less assertive, much more diplomatic. And unfortunately, you could get a lot of sleep centers that'll say, oh, yeah, yeah, we do all that. But then the person gets into that sleep center and they do none of that. So it's very problematic. And this
Hmm.
is a harsh criticism of the field of sleep medicine, because many sleep centers will not change their protocol. They'll go, well, where did you hear that stuff? Were you listening to somebody on a podcast? Did you read some book? Like, I don't know what you're doing, but we don't do any of that. You go to another sleep center. We can't help you. So I say, ask the questions ahead of time, because if they go, no, we're not interested, say, great, thank you very much for letting me know. I'll go someplace else. And that's the only way these things change, when people lose customers because they're not actually giving the services that are needed.
You're absolutely right. And it's interesting because when I talk, obviously the people that I have typically on my show, or the people that are in my world in integrative health, everybody's very open-minded and things like that. But I do say that to some of the colleagues, we talk about, if you're not adding some of these technologies and some of these things that are now tried and true, eventually when the public is looking for all these things, guess what? You're not going to have anyone coming through your doors anymore, because our phone devices, right, and Google is the number
Right.
one place where people are
Right.
looking for their providers.
Absolutely.
The majority of my
Absolutely.
entire practice, it went from having referrals from local physicians in town. They still refer me a lot, and I take care of them too. I mean, I take care of a lot of the physicians directly, but it doesn't work that way anymore. Most of my clinics are absolutely people either finding me through friends and family, word of mouth, or what they can find about things I'm doing on the internet. It's interesting because what I'm doing now, so many of my patients now know how outside of the box I'm thinking, and that's actually driving them to my spine clinic, because they want to talk about, they're like, I know you're a surgeon, but I've also watched your videos where you talk to this specialist or that specialist, or you talk to that OBGYN who now does integrative health, and I think I have a hormonal issue. It's fascinating to know. And they're driving themselves. And so in the sleep world, hopefully I can help to push some of this stuff for you, because this is, as your case, the case that you've made is so crystal clear that it doesn't make sense why people that are trained in sleep, and you have the data to show it, some of the pushback is, we've already been doing it this way. This is how we do it. So people never like to change. Nobody likes to move out of their house and move somewhere else. No one likes to change. Everything is disruptive. I understand that, but it's pretty interesting. The other thing I had meant to say before, in the world of bone health, looking at bone health, what's been the standard of care forever? The DEXA scan, right? So we use these DEXA scans. You get body mass composition, but you also get a T-score. We've gone in our integrative health centers to using something called the REMS bone scan, and there's all these analogies to what you're doing. What does that do? It's an ultrasound. It's radiation free, but it picks up bony architecture that the DEXA doesn't. And so at the margin, so if you're diagnosed with, let's say, osteoporosis or borderline, a lot of times your bone architecture score is actually okay, which means you don't need to be on those high dose, let's just call them, caustic chemotherapy type drugs. On the other hand, if you have a fairly normal T-score, but you are in the risk group, sometimes you have poor bone architecture, and we need to do more resistance exercise and pulsed electromagnetic frequency and increase your vitamin D. So it's the same thing. There are these tests, but right back to what you said, in most of these clinics that are evaluating bone health, they've been doing this forever. So now I'm trying to promote this idea of changing, because it's really changed the way I practice spine and the way we're picking up different things. But they're like, it does not work, because it's just silo. They've been doing it this way for a long time. So I see a lot of the analogies in this way, but obviously this has been a very, very convincing. I think that topic is fascinating. I think what I'd like to one more question before I want to get into the mental health stuff, because I think that's real important. And obviously you've taken care of who knows how many mental health patients over the course of your career. But going back to this bi-level, treatment, just for my own edification, what are the barriers to it? Is it very easy to get those devices? Is there any problem with providers being able to get it? Is there a cost barrier?
It is a little bit more expensive, so the insurance companies have balked at it.
Okay.
And that's what some of the doctors will say, and then they'll write it off very quickly. But what the doctors in sleep medicine don't recognize is they simply have to describe how the patient on CPAP is not getting a good response, or the patient is actually quitting. And you go, well, you don't want the person to stop PAP. You lose thousands of dollars by people not treating their sleep apnea. I mean, it's a horrible risk factor for cardiovascular disease and brain disease. So you would think the insurance companies would like to save lots of money that way. So the sleep doctors only have to say, patient is not doing well with CPAP. Here's the evidence. They're not doing well. We want to switch them to bi-level. It could be that simple, and then they would get coverage. It isn't that big a deal, but convincing doctors to do it is the bigger deal.
Absolutely. And again, you're bringing up all of these points that we keep hammering home over and over. One of my biggest frustrations with current medical, the way we treat, is we treat to the insurance or the perception of the insurance. And so if we perceive that it's going to be harder for us to get something done, we tend to say, it's too much of a hassle. I'm really busy. I've got 25 patients. Nobody's got time to, because I mean, everything needs pre-authorization these days. Like literally half of the work that we do is pre-authorizing things. And my colleagues are very frustrated. Even my cancer, my oncology colleagues, their frustration, I mean, they want to cry from how much pre-authorization they have to do. My pediatric colleagues, ENT, everybody is struggling. And so they go, what do? You take the path of least resistance. So in my world of integrative health, like doing a lot of integrative health, a lot of stuff is just not covered. but I want to offer it anyway to patients, especially a lot of this stuff is low cost anyway, but I don't just tell them what their insurance will cover. I want to tell them what is going to help them be well, because that's the whole point. But in this case, the insurance actually will cover it. It just might take a couple extra hoops, but we can't let that stop us from, doing the right thing, certainly for our patients.
Right. But one other caveat I forgot to mention was that there are some insurance companies, and this is isolated to different places, so it's not consistent, that Medicare doesn't recognize upper airway resistance. It literally functions as if it doesn't exist. And people have been explaining to Medicare for years, like, what are you talking about? So that's the barrier for older people in general. But some insurance companies occasionally will just say, well, we don't treat UARS. You go, well, why not? Here's all this research data. And they go, oh, okay, well, maybe we'll cover that. So that's its own little battle that began back in the 1990s and continues to this day, that some insurance companies will fight treatment. I've treated many, many patients who only have UARS, only. No apneas, no hypopneas, just UARS. And I've had to do battle with some insurance companies sometimes, and usually we win. But if it's a Medicare patient, that patient usually has to buy their own device.
But again, we want to make sure that if that's going to help the patient, we at least offer it to them. Not everyone is going to be able to afford it. We can get into issues of health disparities and all that stuff. But that goes without saying. We still have to tell people what is available. It is just like I did an entire radio show on my frustration with teaching, not prescribing to whatever the insurance company, because I do not remember when I went to medical school. I don't remember the insurance company being in the room having that discussion with the patient-doctor relationship. I don't know what that was.
Insurance companies have zero to do with making a medical diagnosis. They have zero to do with communicating with the patient what diagnosis you're making for them. And they have zero to do with you explaining to the patient all the various treatment options that are available to them, irrespective of what's covered. And unfortunately, like you're saying, even in sleep medicine, the doctors say, well, I don't know about that bi-level. I don't know if the insurance, blah, blah, blah. So it's a problem there as well.
And I don't think, unfortunately, they got their memo that it's a 0%, what their thing is. I think that they think they've become 100% of the decision making for us, which is why, I'm so, going down the path of integrative health, because I want to be able to offer patients everything, irrespective of whether it's covered or not covered. And hopefully they can figure out a way to invest in their own health, because now that we're going to go into the mental health disorders, with the mental health crisis getting worse, no question. There isn't a psychiatrist that I've spoken to that's going to say, well, the good news is things are getting better on the mental health front, right? No one says that right away. They say, oh my God, I've never seen such dysfunction. And obviously COVID magnified at times, whatever, number you want to pick. But if you think about it, the people that I see, again, outside of, just their spine condition, some of them could benefit from some of these things that maybe their insurance won't cover it. If they're on Medicare and they don't recognize that, what if even their cardiovascular health improves, their mental health improves, their chronic pain improves? Why, as a physician that then has this information in my toolbox, why would I not reveal that to the patient? Because I think either I make an assumption they can't pay for it, I'm embarrassed because it's not covered, and I don't want to tell them something, and then I feel like they're going to get mad at me because doctor, why are you telling me something that's
wait? Why isn't it medical malpractice if you don't communicate to the patient about what you know about them that is relevant to their health? How is that not medical malpractice? If you know somebody has a diagnosis, you can't say, "Oh, well, I didn't talk to them because it wasn't covered." That is, I mean, if it's not medical malpractice, let's just call it something worse. It's unethical. No, it's extremely unethical. You have to explain to the patient what you have learned, and you are to detail that for them in whatever terms to help them understand it, and then take the knowledge from there. But you can't withhold the information.
You nailed it right in a nutshell. That is, I did an entire radio show on this, and it's very specific. It's so frustrating to me. And then the other thing that I know that you've had to push back on, and now that we're talking about it, it just brings up, is this notion that we've created in the American mind, but even in the American mind of the public, but also in the providers, that somehow when the insurance company doesn't recognize something and it's not covered, that somehow that is not either not effective or a scam or it's inappropriate, or we are trying to sell them a bunch of snake oil. Even if you have 1,000 papers to support this stuff, somehow our colleagues, like when I know your frustration, they're like, well, if it was so great, why does, United Healthcare not cover it? Well,
exactly.
That it doesn't work that way. And I think these conversations are eye-opening for the general public, and they need to understand how nonsensical this stuff really is.
Well, that's why sleep is going to have its own vanguard approach here, where so many young people already, not just because of COVID, but their facility with technology,
yes,
they're going to just start saying, get me the wearable, get me the telehealth appointment. Okay, I've got the sleep breathing condition. Okay, what do I do? Oh, I do this, I do that. Great. I'll buy that here. I'll buy that in Mexico. I'll buy it in Canada. I'll do whatever it takes. I'm not going to a sleep center. It's a waste of time. That's going to happen. And the sleep centers are going to have to ask themselves the question, well, what are you going to do about that? I mean, you know that some of those patients could possibly do better if they were under your care. And you could also learn by working with these patients. But that vanguard is coming because the number of people who have this problem, particularly the problem of, let's say, insomnia, nightmares, PTSD, and sleep apnea, that cluster, is so huge that they're just going to say, I need treatment. And I can see now I need a breathing treatment. So I'm going to start a breathing treatment. How do I do that? What breathing treatment? I'm going to get some nasal strips. I'm going to get a nasal dilator. I'm going to get a dental device. No, I want bilevel. How do I get bilevel? That vanguard is coming, and those people are not going to want to deal with a sleep center. They're going to say, forget it. There's got to be places out there that sell these bilevels. I've already seen people like this. But that vanguard is growing, and the field of sleep medicine has to ask himself, does it want to join the vanguard and help them so they get better care? Or does it want to ignore them and say, oh, we don't care about that? I don't know what they're going to do. Because when you have these consensus medicine models of care that have taken hold of so many places, they're so entrenched that they are years behind in developing a new model. And I don't know what it takes for them to break out of their silo.
No, I think that's well said, and I think that's going on throughout all of medicine. When you would just look at all these different pockets, we could go on and on. As as our time starts to where I definitely want to cover two more really important topics. One, I want to cover how important it is, because this is important. The mental health crisis, it's just so devastating. I see when I ask my patients, again, they're coming to me, hey doc, I got this disc herniation, or I have this scoliosis, or my doc sent me because I have a whiplash injury and I've done all these injections, and what's the next step? I always ask them about their mental health, because as you know, it plays in dramatically with pain and with what they're going on. But there's so many things you bring up, PTSD and depression and all these things. It's like almost all of my patients have some diagnosis, or they have it, but they're just not diagnosed. Generalized anxiety disorder. We can, just rattle off a bunch of things.
Here's the big connection. The big connection that we learned in the 1990s, and we learned this again through divine providence, because, I'm not a psychiatrist. I'm an internist, and I ended up working in the Department of Psychiatry at the University of New Mexico. Started doing this research treatment on nightmare patients.
Right.
And as the years went on, we kept saying, these nightmare patients are seeing a great reduction in their nightmares with our new treatment we developed called imagery rehearsal therapy, which is non-drug. But you know what? They're still not sleeping as well as they could be. So we kept investigating and evaluating. We discovered that many of these nightmare patients had residual insomnia. Then we discovered, and this was the shocker, Most of them had sleep apnea. So to this day, when I see a chronic nightmare patient, whether it's in my coaching services, whether it's working over at Gateway, behavioral health, whether it's talking with colleagues, most people with chronic nightmares actually have insomnia and sleep apnea. That means they could benefit from all kinds of treatments. And here's the bottom line. What we now know about sleep and mental health is this singular feature: the sleep disorder that is occurring in a mental health patient is not strictly something caused by the mental health disorder. The sleep disorder is independent, it's its own independent disorder. It must be treated with evidence based sleep medicine treatments. For nightmares, there's some great cognitive behavioral treatments. Ours is one of them, imagery rehearsal therapy. For insomnia, there's CBTI, cognitive behavioral therapy for insomnia. For sleep apnea, there's dental devices, there's surgery, there's sleep apnea, and so on. My point is, what we learned in 1998, a colleague of ours, Humans and Dajramji, published a case report of a guy who walked into a sleep center who had horrible PTSD, 4 hospitalizations, multiple either suicide attempts or suicidal ideations scenarios, on multiple different medications, nightmares, insomnia, everything. He goes into a sleep center 3 months later, after being diagnosed with PTSD and treated with CPAP. It's all gone. No PTSD, no nightmares, no insomnia, no suicidal ideation. And when they asked that guy, well, why are you so much better? He gave like the quote they had in the articles, the case report. He goes, well, I'm sleeping better. I think that was the answer. I'm sleeping better. So, and we published a paper just 2 years after that in 2000, showing that people in two small cohorts, one PTSD not using CPAP, one with PTSD using CPAP, and the group with PTSD and CPAP said their PTSD was getting better. So that helped us realize that every time you treat somebody's sleep, you have a chance to independently affect their mental health. Now, keep in mind, if you're in the 1990s and you're talking to psychiatrists and psychologists and researchers, that's unheard of. It's like, that's not proven. There's no such thing. The mental health causes the sleep problem. Just look it up in the DSM.
Yeah.
So, from 2000 on, after we published a landmark paper in JAMA, in 2001, we published a paper showing that nightmare treatment not only decreased the nightmares, it decreased the PTSD. And that's why JAMA accepted the paper and published it. And ever since then, there's been a paradigm shift beginning that says treat a sleep disorder and the mental health gets better. So now we know we have research on insomnia, nightmares, and PTSD. Some research is really great randomized controlled trials. Some research is just, case reports, case controlled studies, but not, great randomized controlled studies. Nonetheless, for everybody who's in the research in this field and is paying attention, every single therapist knows, who's paying attention, that if they can fix a sleep problem, they're going to have so much better chances of treating the rest. And let me give you 2 examples of it. One, out of Long Beach, California, a group did a study very recently where they took PTSD patients getting exposure therapy, which is where you're reliving the trauma and desensitization. And they found that if the group with PTSD treating their sleep apnea and on CPAP, they responded to exposure therapy. The people with sleep apnea, not on CPAP, but they had PTSD and getting exposed, did not respond to it. Night and day difference, night and day, just in that small cohort. And this is what people have been speculating on. And to the point now where I had been meeting psychotherapists over the last 10 years when I talk to them, because I'm very interested in PTSD research and what treatments you use. I'm getting therapists like crazy say to me, we don't do exposure therapy anymore first. We treat their nightmares, we treat their insomnia, we evaluate for sleep apnea. Once we've got that done, we know how easy it is to
Wow.
do exposure therapy. We know how easy it is to do EMDR. Now, I'm not saying you can't reverse it. I'm just pointing out that there's so many therapists now that are beginning to realize, wait, there's this whole dimension that I can incorporate into my mental health field to independently treat the sleep problems of my patients long before I have to go down a pathway of saying, okay, well, you've got this diagnosis, and we got to do this medication. No, let's make you sleep better. And if you sleep better, these other things are going to get better. Let's find out how much better they get, and then let's go from there. That model is already being practiced. And for 10 years now, many therapists are starting that model because they love it. They love the fact the patients are going, wait, you can help me sleep better before you treat my mental health condition? Yes, I think I can. I think that's very possible. They're going, well, this is the greatest news I've ever
Of
heard.
course.
Let's get started. Let's get started.
It's interesting because one of the things that, we are looking at, quite a bit is, like from the integrative health side, we're doing a lot of treating of TBIs and concussion. And and it's
Mm-hmm.
fascinating. I had to go back, when I started doing some of that work on that thing, I had to go back and look at all the basic science textbooks and read all these textbooks on concussion. It's just so fascinating. It's such a black box, and concussions, obviously, even even things that are considered like subtle concussions where people never recover. I mean, it ruins people's lives. It's pretty devastating. But there's that overlap between concussion and PTSD, and many have both. Have you looked at specifically concussion and doing this and treating sleep apnea in concussion patients?
Yeah, I have no research or even very, very limited clinical experience in that realm, but it's more about reading the scientific literature shows you the direction this will take. Because TBI research for a long time has suggested that airway collapsibility changes. And in fact, one of the big ones that you should be looking for, because it's the worst case
Mm-hmm.
scenario, is they don't get obstructive sleep apnea, they get central sleep
Yes.
apnea.
Mm-hmm.
And so when that happens, they've got to be on ASV or one of these other advanced devices. Many of them just get obstructive, but nonetheless, not just. Many patients do have that. There's no question that that is a factor because anything that is messing with your brain and producing sleep fragmentation,
Mm-hmm.
because that's the bottom line. When you got a sleep breathing disorder, you have sleep fragmentation. The sleep fragmentation, therefore, is interfering with the depth of your sleep. It's interfering with the consolidation of your sleep. It's interfering with your deep sleep. It's interfering with your REM sleep. So obviously, you don't feel good. And obviously, your brain is being
Yep.
damaged.
It's just fascinating. I mean, TBI and concussion is absolutely fascinating, and so many really interesting things coming down the pike. It's been frustrating because concussion treatment has been in many ways so passive, especially early on. And if there are things that can be done early on, one of the things we're doing is like I said before, the light therapy, and there's a lot of research currently being done behind that with really good results. But combining that with some of the other typical things, the ocular retraining and the vestibular retraining and the biofeedback and everything like that. But I think we have to take a much more active approach. So it'd be interesting to see what comes down the road as far as treating any apneic, maybe subtle apnea, like
Right.
just a little bit of
Resistant.
upper airway resistance. That's it,
Right.
and then
Right.
treating them with that for their
Right.
concussion symptoms.
Right. So I was just in a conference with some Israeli researchers who, of course, are experiencing unbelievable levels of trauma and PTSD, and we actually had this exact discussion, asking the question of could you do something early by putting people on a bilevel machine?
Mm.
And I went through this whole thing to explain to them because in the whole literature about sleep, there's always been this discussion point that goes way, way back to what's called dream sciences. Long before sleep medicine, there was dream researchers as well. Even before they knew about REM sleep, there were dream researchers. Anyway, I said that if you look at the sleep of these PTSD patients, you often do find the REM is fragmented because of either the PTSD or the sleep apnea or both. Well, REM sleep really often seems to be functioning like a psychotherapist if you look at what REM sleep seems to do. In REM, you remember things. That's what you do when you go into a therapy session. Then you talk about the memory and you learn something. You do that in REM. And then you emotionally process what you learn. And that's what you do in REM. So we said to them, what if BiLevel can put your early trauma patients back into REM sleep right after their trauma? Because unfortunately, with what goes on there, they're exposed to people who are traumatized on a daily, weekly basis. And they can bring them in, they could get a sleep study, and they could put them on BiLevel just like that. I don't know if they're going to go through with that study, but that's what we discussed just a couple of weeks ago because I said, this is a way to understand this because you can look at the fact that there's a research study that was published over 20 years ago that showed if your REM sleep was very fragmented soon after trauma, a guy named Thomas Mellman at Howard University did two of these studies. If your REM sleep was fragmented within 1 month after being traumatized, you're going to get PTSD.
Wow.
And if your REM sleep was stabilized soon after trauma, you probably weren't going to get PTSD. Now, it's not conclusive, but the fact that he did the study twice and he showed a correlation between consolidated versus fragmented REM and your PTSD scores, I mean, that's a biological marker actually correlating with a subjective scale about PTSD. That's phenomenal. So that research is going to be coming one day to show about an early intervention, just like you're talking.
I mean, if it showed that, I'd love to connect the dots on things, but clearly in all these patients, because, we have our group is primarily, I'm an orthospine guy, but we're primarily a neurosurgical group. And so we see a ridiculous amount of TBIs that come through the hospitals that we cover. And obviously the severe ones have a lot more issues than what we're talking about here, because they usually are multi traumas and things like that. But the people that have the more subtle TBIs, be really, really interesting to see as part of their immediate rehab protocol, because often they don't get in to even see a neurology clinic for 2 months because of the way the current medical system is. So what we're trying to do from our integrative health standpoint is at least get the light on their head and get some other, just like really early interventions in conjunction with wherever else they're being treated, but really fixing their sleep right away, or at least the value. It'd be interesting to take these patients right after kind of a moderate concussion where we're worried about them and see what's happening with their sleep fragmentation, let's say by 3 weeks out. And if it's a problem, you need to aggressively, immediately treat.
Right. And I'd love to know whether the NFL is looking at this. I'd be surprised if they're not. But on the other hand, sometimes they just don't necessarily have forward thinkings. I have reached out to some of the football teams over the years, and I know some of my colleagues have as well. Some of them prove very receptive and very interested, particularly because the offensive linemen are big, have big necks, and they figure, here's an obvious. But the concussion protocol, so many people now go into concussion protocol, perfect opportunity to evaluate their sleep, put them on a PAP machine, see if it improves the concussion process faster. Be a great thing for them to do.
We've had some preliminary discussions about the light laser, therapy to the head with the NFL Players Association. Eric Heupel, he was a former quarterback for the Lions. He's really big on concussions and stuff, because all those guys back from those days. I don't know if there's any that don't have a post-concussion symptom, so they're really interested. But
Right.
actually, we submitted for a white paper with Dr. Henderson. He treats a lot of the former NFL players and some of the current NFL players with this transcranial, laser therapy. So
Great.
they are looking at some different, ways to approach that, and that treatment does have some. But combining that with fixing their sleep, with some of these direct, electric current stimulations or transcranial, stimulations. And I'm so excited in TBI concussion because now with AI, you can start, if people are willing to share their data and what they're doing, we're going to be able to aggregate massive amounts of data sets instantaneously and say, hey, this is the protocol, here's a better protocol, and then work on that, and then just keep it. So it's really fascinating. Thanks for sharing all that. This is, I mean, we could talk about this for hours. I think that is sort of the final thing, because people have been watching this, and I'm sure they've gotten tremendous nuggets. This has been fabulous. They're going to just say, well, what do I need to do? What lifestyle modifications and sleep routines? If you could just give just advice on the lifestyle modifications that could help them, and then what their sleep routine should be, I think that would be a great
Right.
way to just at least like end this with what would the average person could just do to sleep better, to
Sure.
get better quality sleep.
Sure. So it's a bit paradoxical in answering you, because I often say to people, forget about sleep hygiene. Because what it turns out to be is, if you really have nothing wrong with your sleep, then you should be able to fix your own pattern and get into it and do it. And if you don't, it's because your commitment to that just isn't there. So that's the real problem,
Yeah.
that you just don't have that commitment. And we all are human. We all have certain excesses. Want to watch too much TV or do too much entertainment or whatever it happens to be. So I focus on the people who actually understand, no, I don't know what it is, but there's something wrong with my sleep. And so I say to them, sleep hygiene is not going to fix that.
Hmm.
Here's what you need to do first. You need to evaluate whether there's something about your nasal breathing that needs to be improved. Because the largest majority of people who say things like, I think there's something wrong with my sleep, have something wrong with their nose. They may have nasal congestion, they may have allergic rhinitis, they may have a very common problem called non-allergic rhinitis that most doctors don't understand. They may have deviated septums, they may have enlarged turbinates. They may have something with their whole anatomy that's such that they don't realize they're not breathing well during the night. And so in my book, Life Saving Sleep, one of the things I spend a lot of time on is called conservative management of sleep disordered breathing. Because there's many people not willing to go out and get a sleep study or
Hmm.
go on PAP. But if you give them something that confirms for them that this is what's going on, now they've got the buy-in. I have treated hundreds of people with nasal strips, and they use the nasal strips and they go, this is crazy. Like, why am I sleeping better with this stupid little thing on my nose? Why? Because you're breathing better. They go, well, tell me more. Tell me more. So in the book, I describe a lot about nasal saline solutions, about the different kinds of nasal sprays that are mostly over the counter, some that are prescription. When people start using these, they begin to realize, you know what? I am sleeping better. In
Wow.
fact, my trips to the bathroom might have even have decreased a little bit, or I don't wake up with a headache sometimes, or I don't wake up with a dry mouth, or I'm dreaming more. Very, very common responses to very simple treatments. So why do we do that? Well, because most people don't like the idea of going to a sleep lab. Most people hate the idea of thinking about CPAP. So why would you start the sale by talking about CPAP? You start the sale by saying, here's simple stuff. If it works for you, guess what? You've just diagnosed yourself with a sleep breathing disorder. You can make the decision. Do you want more? By the way, a lot of people don't. They go, you know what? I really love my nasal strips. I love my nasal sprays. I'm really getting better sleep. That's the routine I'm sticking with. A couple years later, they come back. All right, I'm ready for more. That's fine. That's totally the way it should work. the patient drives it. The only problem with it, and this is the biggest problem we haven't talked about, so I'll make it quick. There's a ceiling effect in sleep, very big ceiling effect. It's almost impossible to know what your ceiling is for getting better, even if you're a sleep doctor, even if you're a world expert sleep doctor. You cannot easily predict how high the quality of your sleep should be. So you'll try this and you'll try that, and you go, well, I feel really great. So that should be where it's good, right? I've been through this cycle for over 20 years and 25 years. I'm stunned at the times. I'm sleeping at a certain level for like 6 months. I go, mm-mm, I think there's something wrong here. And I make a little switch. I do something different. I figure out something. And the next thing I know, I'm sleeping better again. I'm
Mm.
going, wow, how did I not see that?
Mm.
So sleep is a very difficult thing to self-assess. But in the beginning phases, the person's got to find a way to say to themselves, do I think this sleep is a problem? Do I think I should feel better when I get up? Do I think I shouldn't eat as much coffee or tea or soda? Okay, maybe I do have a sleep problem. Why not try conservative sleep breathing treatments and see where that takes me? That's an outstanding starting point for most people who have a complaint about their sleep.
Thanks. I mean, that was great. Real quick before we wrap it up, I hear all these like really doing the saline, rinses. Would you combine using that early on with the kind of the Breathe Right nasal strip inventor is here in Minnesota. He has a beautiful home on Lake
We,
Minnetonka that
I,
I've driven by
I, I,
in a boat.
I,
I've only been
I,
out there twice, but we
yeah,
went by his home.
no. I know them. I know them.
Oh,
Yeah,
really?
he had us there to his place when Jerry Rice
That's
was doing the advertising, and he helped us set up the first research study on nasal strips, showing that it actually does treat people with insomnia and sleep disordered breathing, and it shows that their insomnia gets better. So we got to meet all those people in Minnesota.
Oh yeah, it's beautiful. Yeah, we went by it. Clearly the things work because of where
Right,
he lives. So that
right,
we'll do that.
right.
But what about the saline rinses? I hear
I,
about
I, yeah,
Navage stuff and all this stuff, and that's
those are
not like
great.
okay, great.
Those things are all great unless there's two things going on a person has to remember. If they have sinus problems, they really need to work with a doctor, because if you have a sinus problem and you start messing with all these
Mhm.
things, you can sometimes make them worse.
Okay.
So sometimes it's better to work with a doctor in that sense. And the other thing is if you have non allergic rhinitis, which means that technically something as simple as your nose is more sensitive than most people, you can also cause problems
Mm.
because everything you try is now another stimuli going into your nose, and now your nose might overreact. So I describe all of this in the book, so you get the stages of how to deal with it. Um, but in general, many people do well with simple things like nasal saline, nasal strips, and they start there. And then they investigate more and say, well, what else might I need? A lot of people would benefit from seeing an ear, nose, and throat doctor.
Mm.
But all of this can be staged. And the beauty of it is a person can start to get benefit. And
Mhm.
that's the greatest thing in the world, to get benefit. I did this little thing, I'm getting benefit, I'm on the right track. I'm really going to look into this sleep stuff. I think it's a big deal for me.
That's great. So after all this, people are going to want to know where to find you, where to pick up a copy of your book, how to communicate with you in any way if questions arise. Just let us know everywhere we can find you and how everyone can get a hold of your book.
So you'll find me sleeping comfortably in Savannah, Georgia. And regarding online presence, I have a free Substack newsletter called fastasleep.substack. I have a coaching service, and that's at barrycracomd.com. On that website, there's also other videos and books. Some of the videos are free, some of them are for sale. There's a few books and videos for sale on that website. And then regarding my books, as far as I know, it's wherever books are sold, you can get copies of Life Saving Sleep, the newer book. I have a newer book, Fast Asleep, coming out in a month or so, but that's a smaller book dedicated much more to giving a sort of newer, easier version of cognitive behavioral therapy for insomnia. It's called Fast Asleep. That'll be out in a couple months. Life Saving Sleep is the one that's got everything in it
Yes.
and really has the most bang for the buck.
Yeah, so I can't thank you enough for being on the show today. I tell you, I learned so much from reading the book, and even more from actually being able to talk to the man himself. I think sleep is so integral. I mean, it's such an important part of how we recharge the human battery. That's the name of my radio show, but it is really, we're recharging the human battery. We have to
Right,
find ways
right.
to recharge it. And that is a great recharge for the brain and for all our other organ systems. And when you have dysfunction there, like you said, it's the other way around. It's creating a lot of the mental health issues. And certainly we didn't get into all the chronic physical diseases like autoimmune diseases, all these other things. They're, of course, they're going to be affected by sleep. So many nuggets. I hope that people kind of get the message on the kind of lower version of sleep apnea. I guess what would you call it? UARS is that the way?
Right, right. All kinds of pronunciations. We stick with UARS. That's what Dr. Guilleminault called it. But it is a condition that's worth looking into.
Yeah, and I'm certainly going to incorporate some of that in my practice. Start asking the questions, and when I refer people for sleep studies, I'm going to have those conversations. I'm going to figure out where I can get my patients so they can have that, all those special, parts of the study so we can get the data we need to treat them effectively and look at some of this bivalve, these devices and go from there. But otherwise, this has been fantastic. Thanks for being at the forefront of sleep medicine, making a difference and not giving up when your colleagues, were making jokes about, what some of the hypotheses you had, and it's come to fruition. And you've got guys like me that all I had to do is read the book and talk to you. And it's as obvious as can be. And this is something I haven't studied, but sometimes it's better because I haven't gotten into the sleep medicine silo. So I'm going to go with what the best research is and make my decisions that way. So sometimes it's good when you have, tabula rasa, a clean slate to kind of write on. So thanks so much for being on the show today. Everyone that's watched or listening to this everywhere, podcasts are found, please go to his website. Please read the book. Please work on your sleep and think about making some changes that could make dramatic changes in your life. Again, thanks for being on the show. Thanks for being in another episode of Wellness at the Speed of Light. We'll see everybody on the next episode.
Thank you so very much. Sleep well and prosper.